Good evening to all our participants, and thank you for joining tonight's webinar. Before we officially start our webinar, we would like to call on Dr. Alvin Marcelo.
Yes, thank you, Charisse. I think people are still trickling in, so maybe let's wait for another 3 minutes. And during those 3 minutes, I'd like to
Hello.
just acknowledge
Thì lại
the
cái gì
participants in the call. I think I
bên những
shared
người
Dr.
này thì đây cục
Yeah, Charisse, can you
Yes,
mute Dr. Bunchai first? Yeah,
tổng tăng lên.
can you do that?
we'll find this account.
Dr. Bunchai, can you mute your microphone first? Thank you. Okay, so we have a few new names. We have a few new names. Alicia, welcome. Atish, Athena. We haven't started yet. We're waiting for some people to still log in. Usually, we found out that when we say 9 o'clock, it's 9 o'clock when they start opening their mobile phones and laptops. So it may take some time before they come in. Oh, there's a question from Dr. Fazila. Yes, Dr. Fazila. Do you have a question, Dr. Fazila?
Sorry, Alvin, can you hear me? Hello?
Yes, we're on broadcast now.
Oh, okay. No,
Yes, we are on broadcast now.
Okay, but no, I can't see the attendee's name like before. We know who's on board, but how come this
Yes,
one we can't see?
this is the webinar. So this is for 500 people. Yeah, so it's a different interface.
Okay. All right.
Yes. So only for the go-to webinar, only the organizers are able to see the names of the participants because of privacy reasons and policy. But in the GoToMeeting version that we also have, which we use for our smaller meetings, community of practice meetings, we will be able to see the names of everyone. So I'm just calling out names. I see them. Don't fault me if I don't call your name yet. But some people that I recognize are Dr. Gabriel Borlongan, Carl is here, Rodman, uh, Lauren Walters, Michelle Zera, Pradeep Balchandran, Ronwil Cornell. Hi, Ronwil. Rose Ann Duniga, Sanjay Podel, Sarah Shining, Siddharth Srivastava, Vijay Andragavan, Victoria Rabovskaya, Ismail Zuniga, and I was scroll up. Dr. Fazila, Daniel Futterman, Atina Husnain, Anissa Ristia Ramanti, Anis Fuad, who I'll call later, Alicia Spengler, and Atish Neopani. And I asked Charisse to announce a 3-minute waiting period. I don't know if we've reached that time already. Charisse?
Dr. Alvin.
Have we reached the 3-minute waiting period already?
Yes, Doctor.
Okay, sige, go. We'll start.
All right, Dr. Alvin, for our participants, please be reminded that throughout the meeting. For comments, please use the chat box. We can assist you. And for questions, please use the questions box. Before we start, we want to introduce speakers. So our first speaker is Dr. Alvin Marcelo. He is the Executive Director of the Asia eHealth Information Network and the Managing Director of the Standards and Interoperability Lab Asia. He is also the Vice President and Head for Information Management Group and Chief Medical Information Officer at St. Luke's Medical Center. He is also certified in CGEIT, TOGAF, Archimate, and COVID-5. The second part of our webinar will be led by Mr. Saurav Bataray, who is the Deputy Advisor of GIZ's support to the health sector program in Nepal, where he leads the team on health information systems, a team that focuses on providing support to the Ministry of Health and Population in Nepal to strengthen its routine information systems. Among the many information systems supported through the GIZ program is OpenIMIS. Mr. Saraf has been directly involved in the deployment of OpenIMIS in Nepal since 2014, starting from the initial customizations required to fit the Nepali context to its nationwide implementation and capacity development of users. Currently, he is also supporting the OpenIMIS initiative in its efforts to develop the OpenIMIS software further and to build a community of practitioners around it. So first, we now call on Alvin Marcelo.
Thank you, Charisse. Thank you, everyone, for joining our call tonight. I chatted that I don't see Saurabh, so I also asked Charisse to. Oh, okay. So Saurabh is already here. Thank you. Good evening, everyone. This is our 109th AeHIN hour. For those who have been participating since the beginning, thank you very much. For those who are just participating tonight, welcome to our 109th. As a matter of fact, when we started this way back in 2012, when we were still under the World Health Organization, we didn't know that the way the AeHIN hour sessions would be conducted would be propagated in so many different ways. So right now we have the University of the Philippines College of Medicine who are conducting their own webinars using this same platform, and they have been hugely successful, much more successful than AeHIN actually. Now conducting at least two webinars per week, not on e-health, but on healthcare and medicine in general. So for tonight, I am honored to be presenting together with Saurabh our webinar on OpenIMIS. We're calling it OpenIMIS 101, launching the community of practice. And I divided my presentation um, into the following. A quick brief introduction on OpenIMIS, and I appreciate if Saurabh can add more flesh later on when it's his turn. Some context why we are discussing OpenIMIS in the Asia eHealth Information Network. Then some context about how we see OpenIMIS' role will be in strengthening the Asia eHealth Information Network. Demonstration and walkthrough by Saurabh on some of the main features of OpenIMIS. Not very comprehensive because we can have another session for the details, but just enough for the audience to understand what the software is all about. And then I'll come back and discuss some of the plans of AeHIN for 2019. Because I see some new names in the list of participants like Ronwin, I'll just give a brief statement about AeHIN or the Asia eHealth Information Network. So way back in 2011, WHO gathered Asian country representatives from the ministries of health in Vietnam, and the topic was health information systems interoperability. And the 3-day conference in Vietnam ended with basically the agreement of the MOH representatives that there was really no interoperability happening, even within the ministries of health, the different departments of the ministries of health. So how much more can they actually ask the private sector to collaborate if there is no interoperability even within the Ministry of Health? And if that was the current situation, then health information systems would be difficult to build, and you won't be able to see a comprehensive data about health in your country. So from there, a group of people banded together and called themselves the Asia eHealth Information Network. And from a group of 7 people from 6 countries, we have grown to more than 1,200 over the past 8 years, with representations not just from Asia, but also North America, Europe, and Africa. And I think the reason is the problem resonates with all of us, that we all aspire to have very good health information systems where any health stakeholder would have access to the right data at the right time. But in fact, it is not really happening. It's very difficult, and the challenges are enormous. So, AeHIN, for the past 8 years, we've been meeting at least once a year with support from WHO, ADB, USAID, IDRC, GIZ, and because of this, NORAD and other partners, and because of this, we've been able to grow the network and to refine our concepts. And we've summarized the challenges of health information systems at national scale in Asian countries. And we believe that four things need to happen for comprehensive health information systems to happen at national scale. First, there should be good governance, that there would be a public and private collaboration around the development of national health information systems. Second is architecture, that there should be a blueprint that the public and private sector understands, agrees, and shares, and commit to comply with, so that even as they each work on different parts of the healthcare system, they know that their individual separate parts can actually be interoperable later on when the reporting time comes. After that would be program management, that the stakeholders in the country, public and private, should have the ability to execute their part of the architecture or of the blueprint. And the last one is standards and interoperability, that the stakeholders, public and private, would be able to use the same standards that will be a prerequisite for their interoperability. And only then would be able to have comprehensive national health information systems. And we summarize that into what we call the Mind the Gaps framework, GAPS, representing governance, architecture, program management, and standards. So let me go back to our presentation and talk about OpenIMIS. And as we talk about OpenIMIS, perhaps simply as software, you will see later on that it's not just software, but actually a movement and a paradigm shift. So OpenIMIS is short for Open Insurance Management Information System. If you want to learn more at your own free time, you can go to openimis.org and read all about it. It's open source software that manages the interactions between patient, payers, and providers. This is in the context of a national health insurance system where there would be patients who are members of the insurance system, the payer who would be the manager, and healthcare providers who would then providing service to the patients, and the payer providing reimbursements to the provider. It's currently being used in Nepal right now and Tanzania. And three main proponents of this project are at the bottom: the Swiss Confederation, the Federal Ministry of Economic Cooperation and Development, and GIZ. And soon we will be expanding this in our meetings. We'll be adding AeHIN, we'll be adding GEMB, we'll be adding other partners who are participating in this project called the Community of Practice. So perhaps the context that we'd like to start off from is that we all know that the healthcare is very complex. Um, there are many stakeholders in a healthcare system, and many of them have varying and sometimes competing agenda. Some of them want to get more reimbursements, but at the same time, some of them might want to control costs, and some of them would like to would like to get the best quality care, but at the lowest price possible. And sometimes, that can be very challenging when you need some technology to be able to get the best quality for yourself. And then in between these stakeholders that have competing agenda, they have interactions between each other. And these interactions, some could be very mature, like a patient-doctor relationship is very mature, but some are not that mature, especially if you're just starting out your national health insurance system and the insurance agency has not yet established a good base or a good foundation for operations and management, and being able to convince the people or the members that they are able to provide adequate benefits to the patients or to the members. It's definitely resource intensive on health human resource, on technology, supplies, medicines, salaries, and oftentimes there's a wide variance on what stakeholders define as quality. They might require a lot of quality in quotation marks from the other stakeholders, but for themselves, sometimes they might be compromising on what should have been quality services that they should have been providing. So because of that wide variance and let's call it the ambiguity of what we mean by quality, sometimes there are conflicts that occur with the interactions between the stakeholders. And often the entity that would suffer the most would be the patient, because the patient is just an individual and the other stakeholders are larger entities like the ministry, the pharmaceutical companies, the network of hospitals, the society, the professional societies of doctors. So, and government here is basically the organized group of citizens, and hopefully government would then be espousing the the needs of the citizens. So here I present, I did say that there are many stakeholders, but I try to just extract the minimum that we know happens in a environment where there is health insurance. So I call this the core model, and this would be the ideal, that you have at least the patient, the provider, and the payer interacting with each other. A patient would feel something, and so the patient consults the provider, and the provider in turn treats the patient. The provider then from claims submits a claim to the payer, and the payer reimburses the provider, and the patient contributes premium or membership fees to the payer, and the payer then protects the patient because of the payment that they get. And ideally, each of these entities actually behave in a certain way. The payer actually pools the risk of all the patients, and therefore he collects all of the premium, gets a substantial amount of money, and then disburses the money effectively to pay for quality services that the providers are giving their patients. The providers are, in turn, should be providing quality care. This is care that actually becomes beneficial for the patient, that is not wasteful. And WHO has a very comprehensive definition of what quality actually means. So I won't take the spotlight from them. I would refer you to WHO definitions on quality. And of course, the patients. This is the hardest part, because our role and our ideal behavior is to maintain a healthy lifestyle. Uh, just eat balanced diet and then make sure that we exercise. But the reality is, the current core model is that patients, as much as possible, are afraid of going to the provider when they get sick, and sometimes they actually go to the provider when it's already late. Some providers treat based on what they think is right, but often not based on evidence. Some providers claim unfairly from the payer, asking for more than what they actually provided. And on the other hand, the payers do not pay enough for the quality care that providers give. So they only pay a percentage, and therefore it becomes hard for the provider to provide quality service without then exacting a partial payment from the patient. On the other hand, there are patients who are unable to contribute premiums to the health insurance system, which then makes the payer unable to protect the patient. So essentially, OpenIMIS offers really the opportunity right now because we're now in the context of the Sustainable Development Goals for 2030, and specifically on SDG 3 that focuses on healthcare, especially universal health coverage. We find ourselves in an environment where there's a political readiness to espouse good health values like universal health coverage. At the same time, information and communications technology has become very affordable and accessible to the common man. And in this case, ICT as used in healthcare is what we define as digital health, or sometimes previously called e-health. And we now know that ICT used properly can help standardize and streamline various processes and interactions that we showed that are in support of universal health coverage. So the hypothesis that is playing around in our mind is that if there was an ICT system that standardized these processes, will stakeholders behave accordingly? Will will they be able to achieve better health as patients, provide better quality care as providers, and provide better support to patients and providers if you are the payer? And that's where OpenIMIS comes in right now, just as open source software, but soon, because of the communities of practice that we are forming in AeHIN and in Asia, hopefully not just software, but a movement. And the premise is we think we can achieve universal health coverage if there was a community of practice of stakeholders who understands the fundamental principles of universal health coverage, who are willing to play their role responsibly in the core model, who know that there is a need to change from the current system to a new system, and who recognizes the value of ICT as a key strategy in that change. So from the current model, we hope that we can reach the ideal core model, and we're seeing how a simple set of software like OpenIMIS, together with the people who are involved and concerned with this change, can start the ball rolling, so to speak, in that transformation. And this is what we call the AeHIN OpenIMIS community of practice. And we got support from GIZ to start the thinking process and the thought leadership as to how a very simple set of software that's actually being used in production in Nepal and Tanzania can be the starting point of that transformation of the use of ICT for universal health coverage. So at this point, maybe you're interested what OpenIMIS is and what it can do. So I will call on Saurabh. Saurabh, I still have your slides here. So either you can control my screen or I give you control. Okay, go ahead, Saurabh.
Control of the screen now.
Take it away.
Yep. Can you see my screen?
Yes, go ahead. Yes.
Oh, okay. So yeah, as Alvin just pointed out, I will be going through some of the features of OpenIMIS. And most of the demonstrations, all of the demonstrations that I'll be doing will be based on the demo server that we have up and running on demo.openimis.org. So you're welcome to play around with it once we're with the session here. And as Dr. Alvin had mentioned, is a software that tries to connect payers, providers, as well as patients together. And but in terms of actually using the software, OpenIMIS is set up on the payer side. So the payer would be the owner of the restrictions. But if you have more questions, please feel free to reach out through the wiki or through email, whatever you prefer. So we'll be going through system setup in terms of defining where services are available, what services are available, and then what is the insurance product. So from purely a payer perspective, setting up, let's say, an insurance scheme or a social health protection scheme. We'll go through briefly these functions, and then get into some of the processes that are that OpenIMIS helps streamline, particularly enrollment, claim submissions, and then claims review. So if we go into system setup, again, I will now switch over to the demo system. The login ID and password is displayed there, so you can use it, use that to play around with it later as well. So let me just log out real quick. And so this is what you would be greeted to when you go to the demo site. And then the administrative username and password should be auto-filled in for you. If not, it's displayed on the slide. So initially, we would go through system setup, and as I was saying, let's look into location. So this will define the geographical coverage of your social health protection scheme. So here you can see you can have regions, districts, municipalities, and then villages. So 4 levels of administrative boundaries that you can define in OpenIMIS, and this is where the scheme would be active for people to enroll or services available. It's pretty straightforward. You just keep on adding regions, then add districts within the regions, municipalities within districts, and then villages. On the villages, you see there are functionalities to add population, so the male population, female population, and the number of families. And this is really useful in designing a capitation-based insurance scheme. So the populations would actually feed into that. So once we're done with these locations, another very important aspect is to provide information on where these services are available in terms of health facilities. So you can go here to the administration tab again, just like we did during locations. Then up here, there's a tab called health facilities, a button, and this is what you would see. So we can add new health facilities here. And this would be, you get a lot of options in terms of what are the different, entering in the different location information, as well as the different types of care provided. Is it only an inpatient service provider, outpatient, or both? And mind you, these can all be configured. If you have a deployment where you need different configurations, OpenIMIS can be configured to a certain point, and then beyond that, you would have to customize it, which is also possible since all of the source code is available right now. So again, and then one of the more important things here is a price list. So each health facility can be defined a different price list if that is how your social health protection scheme is defined. So you can have different prices per facility, or you can have it per region, or you can just have one national price list. So this is how you would define health facilities. Another major part of system would be to enter in information in terms of medical services. So what services are available in this social health protection? You can see that there are available, so you can get a different code. And this is where I'd really like to link to what Dr. Alvin was saying, OpenIMIS system. So if we can start using standard codes, if OpenIMIS, and this is in the roadmap that we promote international standard codes, then we can really push this into a health system and make sure data from different systems are actually interoperable. As with other information, we can enter in name of the service provider. Is it a preventive or curative service? What level is it? And all of these level, price, and then care type, is it a inpatient, outpatient, or as both, as well as the 4 different types of patients and their different combinations. These are all used as rules when later on claims would be reviewed. So if right now we just have we select a woman and an adult and define the services accordingly, this service would be rejected for insuree who's not an adult woman. So if a adult man claims this particular service that we would enter here, it would be rejected. So all these different rules can be programmed into OpenIMIS. So once we have these set up, and there's a, as you can see, there's a default price in there as well. Once we have all these set up, OpenIMIS segregates services and items. So before, those were medical services, and then a very similar screen for adding medical items. So these would be drugs, prostheses, and all the different other medical items than services. So they can be added here. So once this is done, and as you saw before, there was a default price. You can create different price lists, as I mentioned before, for medical services and medical items. So you can create price lists that are just the default prices that you entered when you were defining medical services here, or you can define different one for different, as I said, regions or facilities, whatever the need be. So all these things can be defined. And then the only thing left for an insurance is to actually define the insurance product, like what benefits are available and what are the contributions that are required. And this is after all the other systems have been set up. So there is a screen here from, under administration called products, and this is where the insurance scheme would be defined. And when you click on add this, you would see this screen. These are all the different options for defining a health insurance scheme. I will not go into detail in the interest of time about each and every cell here, but all this information is available in the detailed documentation of OpenIMIS. And if not, if you have some confusions, you can always reach out to us. But all in all, this is where you would define what medical services and items are available in a particular insurance scheme, when it's valid, how much it costs to actually get into the scheme. So what are the contribution amounts? What are penalties for, let's say, a delayed renewal, or what are grace periods? What are renewable discounts? All these things can be configured on this screen. And once this is done, generally there are not a lot of schemes promoted by the same insurer. Once this is done, then the system setup part of OpenIMIS would be complete. So as we saw here before, we've seen briefly how we define service delivery points in terms of locations and health facilities, how we define services, and then how the insurance product is defined. But now we'll get into one of the other features of OpenIMIS as a management information system tool. It facilitates a lot of processes within insurance. And one of the processes that is quite unique compared to other systems is the one for enrollment. The enrollment process in OpenIMIS is designed for the informal sector. Currently, while efforts are in place already to include a formal sector enrollment module into OpenIMIS, the current system is very much aligned to informal sector enrollment, where, as I put here, a typical enrollment scenario is having an insurance agent visiting a potential insuree's home. So this is a step-by-step on what happens in Nepal right now. And once the agent is at the insuree's home, they fill out a registration form per insuree, and this is done by hand. So this is a handwritten form. I will show you an example of a form later on. And one of the unique things is each of these registration forms have a unique QR code printed on them. So this makes each and every form unique. it does increase the cost of printing slightly, but the benefits that it provides are quite high. So the investment is worth it. So with these QR codes, what the agent does is it scans this QR code using the OpenIMIS Android app. So we have an app for enrollment, and takes a picture of the insuree. Once the QR code is scanned, then with the same app, the agent takes a picture of the insuree, which ideally, well, not ideally, but what it means after this process is that the QR code on the form is linked to the photo of the insuree. So there is no more need to ask for a physical photograph and paste it on an enrollment form. So we don't need physical photographs of any of the people being insured. And then the bottom part of the form is torn off and folded into a card. And then the rest of the form, the top half of the form, is brought back to the insurance office for data entry. So just as an example, this is, it's written in Nepali, but this is a sample of what an insurance form looks like. As you can see within the red boxes for highlighting, this is where the unique QR codes are printed. And as you can see, the dotted line here on the bottom quarter of the page, this is where a perforation would be there for easy tearing off of this piece of paper. So an insurance agent would fill out all the information on the top as well as the bottom part of the form. Scan one of these QR codes. They are the same QR code. They are repeated on the bottom and the top half of the form. They scan this QR code and then take a picture. They scan it using the Android app and then take a picture of the person being registered with the same app, and then they send it to the OpenIMIS server. So what happens is, so as you can see, this is the app. They enter in the information about the agent or the officer who's on site. The CHF ID, this is the insurance ID that shows up after the codes are, the QR codes are scanned. The bottom half is torn off as such. And then that is provided, folded in half and provided to each family member as their insurance card. So as you can see, this is a process that has helped reduce costs considerably, as in we don't need to print very sophisticated cards, smart cards. We don't need pictures from each insuree, and we don't have the administrative burden of going back to the household to provide them the card. So this card is provided at the time of enrollment. So all of these processes happen at once. And then the remainder of this form, the top half, which you see here, is sent to the insurance office for data entry. So I'll briefly show you how this is done. So someone at the health insurance office would be using OpenIMIS, this web app. They would go to the insuree and policies tab and then add a family or a group. And this can be a single family or a single person family or a multiple person family, depending on what type of scheme this is running. And this is where they would enter in all the information that they collect from the manual forms. And then this is where they would enter the insurance number, which is linked to the QR code. And this is how, I don't know if this example would work right now because we don't have live enrollment going on. But once you enter in this number, there would be a provision to browse for pictures that have been uploaded through the web app, from the Android app. So that way, this insuree, when it gets added, they would have, this would be linked to the picture, and again, completing the file so that there is no need for any physical photographs. So what that would mean is a system is fully complete with pictures on the OpenIMIS servers and people registered. So, and that can be used later for verification. Let me show you an example of how someone can be verified once a picture is provided. So I just have a code here. So if you enter in a code on top, and then hit the green button. This is where, so you would see the picture of the person that was enrolled that would come up, and then details of their insurance policy would also show up after their forms have been fully entered through. So this is how, and as you can see, without having to take physical pictures from people, we were able to have a system, an insurance system that can still display photographs during verification time. So this is how the enrollment process would work. And as I said before, when we add a family or a group, we can add a single person family if the insurance scheme is for single one person, or we can define multiple people into a family and then have an insurance policy that relates to them. And then the next process that we would go through after enrollment is claim submissions and review. So claim submission and review happens at two different places. Claim submission happens at the provider part. So this is the health facility. After they have provided services to the patient, then they submit a claim to be reimbursed by the payer. And then the claim review happens at the payer end, where they receive the claim submitted from providers, they review it, and then provide payment based on this review. So again, I would go back to the demo version to show you how this is done. So as an example, let's take an example of a health facility entering in a claim. We would go into claims, health facility claims. And since I'm logged in as admin, I have to fill in an extra few points here. But if you were just logged in as a person from a health facility, all of these would be filled out automatically. So just information about the health facility. And then so once these are all filled out, then we go into the process of adding a claim. So once we click add here, we'll get a screen that looks a little bit complicated, but it has all the information. It has ways to capture all the information that we need for claim to be complete. So on the top left here, we enter in the insurance number of the patient. So obviously that has been kept by the health facility. The patient name and all of the other information related to the patient will show up once the insurance number has been provided. On the top right, we have the visit date from and to. So this is the information that is required to say, when did this particular patient visit this health facility? So when did they arrive? When did they leave? And again, there are other dates. So a little bit to the left, the date claimed. So this is on the live version, this appears automatically. So this would be the date the health facility is claiming. A claim number is a unique number per each claim. So this can be created by a health facility or pre-populated or provided in advance from the payer. And then to the left of that is where the ICD-10 diagnoses codes are to be entered. So all the ICD-10 codes are listed here, and health facilities can select what the main diagnosis was, and then secondary, and then tertiary, and then even up to four more diagnoses ICD-10 coded if required. And then they would enter in what visit type it was it an emergency or referral? And these particularly the visit type also has implications in terms of how claims are adjudicated. Below that is where now services would be entered. So this is where, as you remember from before, when in the administration tab, all the medical services and items that the medical services particularly that are available in the scheme would be listed here. And whenever, so whatever service was provided can be clicked the quantity appears as 1 as default, and the pre-agreed pricing. So either from the price list or the defined or the default pricing, the price appears here. The health facility can go on adding the different services that were provided, if there were more services, and then they do the same with items. So then they enter in items as they whatever was provided. So if some drugs were provided, you click on the item code, you enter in the quantity, the pre-agreed pricing per unit appears here. And then if you look at the top right-hand corner, the claimed amount is the full, is the total of the services and the items, including the multiplication for the quantities. So once this is filled out, a full claim has been entered. And this can be submitted, so first saving and then submitted for review to the health institution, to the payer, sorry, from the health institution to the health insurance scheme or the payer. So this is how it would be done. So I wouldn't go through the process of clicking save and submit, because that would take some time. But then the last function that I would briefly go through is having the claim being reviewed. The information, so this is all the information a claim would contain, and this information will be available for the payer to review from the claims and from the claims menu by clicking on the review option. So this is where everyone, the payers, the medical review team, or whatever kind of team is available at the payer at the health insurance office would be able to select various claims that they want to look at, and then they can either approve or disapprove claims, or partially approve or disapprove claims as well. So as I just entered in some information that they could use to actually select claims, but since the list is quite long, we have a large data set. I'm just trying to see if we can find a few claims that can be shown here. So this is how you see this list of claims over here. This is how a claim reviewer would see. They would see each and every claim, when it was claimed, what is the claim number, the health facility, and these are claims that I'm showing that have already been adjudicated upon. So some have been rejected, some have been checked and passed on, and some of them will also be evaluated. But the claim reviewer can click on each of these claims and then click on the review button and actually see the details of the claim. So here we're having, because this is not a live system, we are having some issues showing all the services that were claimed and items. But generally, if you look on top, this is all the information of the patient and the diagnoses and the date claimed and all the different information. What you would see here are the services that would have been listed and the items. But because of the data set that we have, not all of it is visible right now. We're working to fix this as soon as possible. But then each reviewer would have an option of accepting or rejecting every claim from here. So this is how a health insurance provider would look through each and every claim, and they can select some as a sample, as a random sample. So as you can see here on this screen in the very middle part, you can select a number of claims for review on a random basis, so as a certain percentage, or as below or above a certain value. from here, and then a certain percentage of variance from the fixed pricing that has been agreed on. So all these options are available, and the claims can be evaluated on batches once the reviews have been done. This is where OpenIMIS process-wise stops. After this, the review status of claims, we have other reports from here focusing on enrollment status and everything. But otherwise, these are all the functionalities, major functionalities of OpenIMIS. And this is where I would like to stop for now. And if there are other questions, please reach out through the wiki or email, and we can discuss them further. Thank you.
Thank you, Saurabh. Thank you for that quick demo. I know that there are more features, but we have to keep our time. So let me go through the rest of my slides. So now that you've seen the basic features of OpenIMIS, allow me now to show you some next steps that we plan to do. So for 2019, AeHIN hopes to develop communities of practice in interested countries. And so far, we've had expressions from Thailand, Philippines, and Indonesia. And I hope that after this call, we would be receiving expressions of interest from some of you as well. We wish to nurture these communities of practice and allow them to think of ways they can strengthen universal health coverage concepts, open source software concepts, health education and collaboration using the OpenIMIS software, and provide them with external experts as resources, provide them with a webinar platform for better collaboration within their country, provide them with an online training platform, and provide them with OpenIMIS on the cloud. So each of these countries will have their own OpenIMIS versions on the cloud that they can now configure. You saw the Nepalese version, and those would have the geographic units in Nepal. But if you are a participating country, then we would put in the geographic codes for your country in your own country OpenIMIS. That would be at the country level. So there will be activities in Thailand, activities in the Philippines, and activities in Indonesia. But once a month, at the minimum, or more frequently as needed, we would be interconnecting this country communities of practices into a larger regional COP through teleconferences and sometimes in face-to-face meetings. And finally, we wish to connect the regional AeHIN community of practice to the larger global community. So specifically for Philippines, we wish to identify interested medical and nursing schools with the focal point of a faculty member, and we would be using the current OpenIMIS manual of operations and extend that for use in their clinical skills lab. Most medical and nursing schools already have their clinical skills lab where they perform services to the mannequins, and these services to the mannequins are actually reported in a piece of paper which they submit to their instructor for monitoring what skills or procedures they've been able to do. So we think that we can use OpenIMIS very simply as a way to report services that have been rendered to the patients, and also as a way for very simple documentation of services rendered to the patient. For this, we would be providing OpenIMIS on the cloud to these schools and train their faculty and selected students on how to use OpenIMIS for that very, very simple clinical skills lab setting, which is recording or documenting a specific service provided to the mannequin. The mannequin here, in this case, would be named according to the name of the student, and the student can now use OpenIMIS as a way to track what procedures have been performed. The faculty member in the skills lab will then serve to be the OpenIMIS administrator, and they would be able to accept and reject the services or the procedures performed by the students. Now, in some cases, and we'd like to encourage some of the schools who are participating, they might want to implement OpenIMIS beyond just the clinical skills lab, but also use it as a way to start their own internal insurance system. I know that there are some medical schools already that are running a internal school-based insurance system so they can use OpenIMIS to monitor the contributions and also monitor the benefits provided to the student members of that internal insurance system. For the Philippines, our focal point is Christine, who is our secretariat in AeHIN, and myself. But we are now contacting faculty members from the University of the Philippines and St. Luke's College of Medicine, and we hope that at least two medical schools will be participating in this project. For contact, you can send an email to secretariat@aehin.net. For Thailand, I don't know if Dr. Bunchai is in the call. I heard his voice, but I do not see his name in the attendees. They plan to get to understand more about OpenIMIS. This is actually the Ministry of Health. And then to understand how to map their existing current needs with existing OpenIMIS functionality. The focal point is Dr. Bunchai Kitchenayotin, and the hub will be his office, the Thai Health Information Standards Development Center. And if you're interested in knowing more about what he's going to do, you can send an email to kijs0001@gmail.com. For Indonesia, we'd like to call on Anis. Maybe briefly, Anis, you can tell us more about how you plan to use OpenIMIS in your Indonesian community of practice.
Hello, Dr. Alvin. Sorry, I think Dr. Anis got disconnected.
He got
Oh, there.
disconnected, but in our yes, thank you. In our last discussion, Anis was planning to engage the Masters of Public Health program in the University of Gadjah Mada and to allow them to look for opportunities for using OpenIMIS in public health education. They actually have a master's program in health insurance, so he's very, very much interested in finding out using OpenIMIS again to concretize some difficult concepts in health insurance management and to also show how ICT can improve management of a national health insurance system using OpenIMIS. If you're interested in knowing more about that, please contact anis.fuad@gmail.com. So with those three countries, we'd like to know from this call, if you're interested, we're looking for focal points specifically for Cambodia, Laos, Myanmar, and Vietnam, but other countries are welcome as well. And if you are, please send an email to secretariat@aehin.net. And we've reached the point where we can now entertain your questions in the open forum. So maybe, Charis, can you help me with the questions?
Yes, Dr. Alvin. So we have our first question from Dr. Carl Stroman. It's about ID safety. So he's asking, do pictures really help? For example, a credit card companies to ineffective, and what is the experience with ID theft?
Okay, so are there two questions there? The first question is ID safety. That's why, Carl, we are not in the Philippines. We are using it in a laboratory setting, not in a real world setting. But maybe I can ask Saurabh, can you field that question because you're now actually implementing that system in Nepal?
Yeah. We haven't had a lot of issues we haven't heard of any particular issues of ID theft, but one of the main learnings from insurance schemes before was around people not bringing cards, and you couldn't verify if a certain person was who they claimed, and they couldn't check their validity as well if their insurance was still active. So the ID cards are really helpful in that, and even pictures for some people, because if just a name, the ID card that we use does not have information such as age, because that would change. They do have date of birth, but it's quite complicated. When everyone's in a rush, it's difficult to calculate age. If they can see a picture and just look at the person, then much more easier to verify. But before we've had particularly not theft as in such, but in smaller community-based schemes, using of the same card between non-immediate family members. So the same scheme would be, the same policy would be used by people beyond the family as well, not as in theft, but just sharing of cards. So this has been a good way to prevent that to a certain extent as
well. Okay, thank you.
Thank you, Dr.
Charisse?
There's also another question, Dr. It's also Carl. So his second question is, do injuries also always go to the same doctor, or do they do doctor hopping?
Okay, so me first, Saurabh. In the Philippines, they do doctor hopping. So for sure, the patients and the policy in the Philippines right now allow the patients to choose their doctors. But I know for a fact that our Philippine Health Insurance Corporation, or PhilHealth, is trying to create a system where there would be a designated gateway physician where they must go first, and then from this physician they could then be referred to other physicians. This is very challenging and always a problem, especially in developing countries when systems are not in place. But in fact, when this happens, then that's where the portability of the patient record becomes very, very important. Saurabh, how about you?
In Nepal, we foresaw that a lot of people would just hop between health facilities more than doctors. And one of the function requirements and defined by policy in Nepal is when someone enrolls, they have to select something called the first service point. So they have to go to their the closest primary care facility, and they have to select it during enrollment. And if they go there and then get referred through the health system, then the insurance pays for it. But if they jump to another facility, let's say a higher level facility, without going to their primary care provider in cases beyond emergencies that are not emergencies, then the health insurance wouldn't cover it. Right, so these are, and that can be defined in OpenIMIS what your first service point is.
Yes, that's the same policy that the Philippine Health Insurance Corporation is also formulating. I think that's a good balance between um, having some system in terms of making sure that you're optimizing the services of your primary care provider, which is your first health facility, but at the same time allowing that flexibility to also be able to see other doctors for as long as the primary healthcare facility is aware that that is actually a better quality service for the patient. Charisse?
All right. Our next question is from Dr. Pradeep. He's asking, does the current version of OpenIMIS facilitate user interfaces for biometric-based patient authentication, for example, for patient enrollment and claims submission processes? And if not, is it a future consideration?
Saurabh, I think that's for you.
Yep. So currently, there is no biometric authentication, and what the OpenIMIS initiative is trying to do is not only focus on as in the roadmap on authentication, but we're looking into modularizing the system as a whole. And if you follow through on the wiki, and we'll have more information on this as time progresses, we already have a company working on modularization. Then we'll have open APIs where different technologies for biometric authentication can link in. So I speak for Nepal. In Nepal, there will be some issues if we bring, let's say, fingerprint authentication because of cultural issues and some past practices. It would be a problem, but somewhere else it might be the solution that is required. So OpenIMIS will be designed. The next versions will be designed in a way that it's modular enough that if someone requires biometric authentication, a module can be built for OpenIMIS for it.
Okay, Charisse, we're running out of time, so maybe one last question.
All right.
So I see what technologies have been used to build the tool. Saurabh, this is MySQL. Correct me if
Yeah,
I'm wrong.
no, right now it's Microsoft SQL.
Yeah.
Right now it's Microsoft SQL and ASP.NET. But the software has been licensed as AGPL for open source. It can run on the free edition, the Express edition of SQL Server. But again, the redesign, the re-architecture will make sure that the entire stack used is also open source. And if I just take the question right following it, the timeline, please follow on the wiki. Will have an updated timeline in terms of when we expect the next versions and what the features will be. Generally, we're looking at 2 to 3 releases per year.
Okay, so thank you very much. We've reached exceeded our 1 hour. If you are interested in participating in your country community of practice or in the regional community of practice, please send an email to secretariat@aehin.net. Thank you, Saurabh, for our demo and walkthrough and for the information. We'll be having this on a monthly basis, but we'll also be conducting weekly meetings with some of the countries and finding out what innovations they have thought about in terms of promoting concepts of UHC, open source software, and information management information systems. This is Dr. Alvin Marcelo. Thank you very much, everyone. For those who are in the call who have not been able to communicate, I'll be available by email and let's talk about things that we can do together. Thank you. Good night.
Thank you,
Thank you,
everyone.
everyone.
Good night.
Thank you,
Bye.
Saurabh. Are you in Kathmandu?
Yes.
All right. Take care.
All right.
Good night,
Bye-bye.
everyone.